Good afternoon, ladies and gentlemen. First, I'd like to thank the organizing committee for inviting me to participate in the 4th Congress of Arab Thyroid Association. It's really a great pleasure to be with you. I'm a pediatric endocrinologist, and I'm going to discuss a really controversial issue, which is pediatric subclinical hypothyroidism. And I'll try to answer a difficult question: to treat or not to treat. And this is the latest definition published in 2023 for subclinical hypothyroidism. And you all know it is a biochemical diagnosis when we have elevated TSH with a normal T4. And surprisingly, 80% of children and adolescents are asymptomatic at the time of diagnosis, which is different than adults. So when facing a child with subclinical hypothyroidism, these are the frequently asked questions, and hopefully I'll try to answer them all. Is it transient and will resolve? Could it progress to overt hypothyroidism? To treat or not to treat? And this is the most difficult question. And if you decide to treat, is it a lifelong treatment or not? So this is the clinical course of subclinical hypothyroidism. And please be aware, I'm speaking about children, which is totally different than adult. Is it transient or for life? The question we are all asked by parents. It's good to say that 50% continue as subclinical hypo. They're not going to progress. 40% revert to euthyroidism, which is again a very good percent. And only 10% develop overt hypothyroidism. And this applies to children. Now, this is a recent article published in 2023 on subclinical hypo, putting the risk for developing overt hypothyroidism. And the conclusion here was that the risk of progression of subclinical hypothyroidism to overt hypothyroidism is low in children and adolescents. The majority remain either subclinical hypothyroidism or resolve spontaneously. And the main predictors for worsening to hypothyroidism are higher TSH level at the beginning and the BMI Z score. So looking deeper at the course of subclinical hypo in children and adolescents based on etiology, the box on the right side, the pale blue box, shows you a list of causes. 60 to 80% is due to Hashimoto thyroiditis, which is the most common. And a long list lies in between. In addition, there is the idiopathic hypothyroidism. And please remember that idiopathic subclinical hypo is usually self-limiting. And subclinical hypothyroidism usually progresses to overt hypothyroidism if it's part of Hashimoto thyroiditis or associating autoimmune disease or chromosomal aberrations. And don't forget to exclude drugs in any child with subclinical hypo. Simply, there is a long list of drugs that could lead to this, especially antithyroid and antiepileptics. And this figure shows you hormonal changes during evolution from subclinical to primary hypothyroidism. And you can see that the subclinical hypothyroidism lies in the category of mild hypothyroidism. And then the subclinical hypo is further classified according to the TSH level into either mild subclinical hypothyroidism when the TSH ranges from 5 to 9.9, or severe if it's 10 international units per liter or more. Now, coming to the difficult question: to treat or not to treat subclinical hypothyroidism in children, and the answer: which way shall we go? The answer in most of references is there is no clear consensus till now to follow. And let me take you to this real life case scenario of this 8-year-old boy who came to me with accidentally discovered subclinical hypo. He was going for tonsillectomy and thyroid functions were done, and the BMI and the height were normal, negative family history of thyroid disease. The boy is asymptomatic with no goiter, and accidentally the doctor found highish TSH 7.8, T4 being normal, thyroid antibodies negative, ultrasound normal. And the question to me was, would you like to treat or wait on this boy? And to be honest, I would not treat this boy because this is what we call idiopathic. There's a negative family history. The boy does not have symptoms, normal weight and height. TSH is less than 10. Antibodies are negative, and the ultrasound shows no pathology. So I did not treat this boy. Now, the boy came to me for follow-up 6 months later. Everything was nearly the same, but the TSH jumped to 12.2 international units per liter. And the question came again, to treat or to wait. At this point, I decided to treat this boy because if you have a TSH of more than 10, you have to treat even if he does not have any risk factors. Another story is this 10-year-old boy who came with BMI SDS on the high normal, height on the low normal, maternal aunt with history of Graves' disease. The boy was asymptomatic with grade 2 goiter, as you see. The TSH was highish, 8.9. The T4 is normal. Antibodies of thyroid were positive, and the ultrasound revealed goiter with heterogeneous echo texture. So there is some pathology. Again, the same question. Would you like to treat or wait? And this is a controversial case. Some pediatric endocrinologists would treat, others would not treat. I would prefer to treat, although the TSH is not above 10, because his BMI is getting higher, although it's not above the normal. His height is in the low normal range. History of autoimmune thyroid disease in this boy. There is goiter, and the antibodies are positive, and even the ultrasound showed pathology. So I think this is a risk factor here, so better to treat such a case. Now, this 7-year-old cute obese girl came to me with a BMI plus 3.6. She's obese, she's tall. So this is not an endocrine obesity, this is exogenous obesity. Negative family history of thyroid disease, no goiter, T4 normal. Again, this number of TSH 8.11 highish, what I call highish, the antibodies negative, the ultrasound normal, and the parents came with the same question. Would you like to treat or not? So in such a case, this is simple or exogenous obesity. The girl is tall, she doesn't have any risk factor, TSH below 10. So the good answer is to wait, not to treat. Of course, obesity alters thyroid function, and various degrees of obesity can lead to subclinical hypothyroidism or even primary hypothyroidism. Not even this. Long-standing subclinical hypo predisposes to features of metabolic syndrome, in addition to obesity, like insulin resistance, dyslipidemia, hypertension, leading to long-term cardiovascular disease. And obesity even aggravates the situation. It leads to more subclinical hypo and metabolic syndrome, which leads to more vicious circle, and the vicious circle goes on. So obesity increases the fat mass and the serum leptin, which increases the TSH, leading to subclinical hypothyroidism. Obesity also increases the free fat mass, which increases the T4 disposal, leading to low normal or low T4, which increases rise in TSH more and more, and this leads to increased T4 secretion, another vicious circle. In addition, increased free fatty acid and the chronic inflammatory process with obesity creates a degree of insulin resistance and metabolic syndrome, leading to subclinical hypothyroidism. And this is an article that compared Danish lean and obese children regarding metabolic parameters. And the conclusions were that higher prevalence of subclinical hypothyroidism was more among obese than the lean, and that central obesity, independent of the overall obesity, is a risk factor for occurrence of subclinical hypo. And this is another article published in Endocrine Journal in 2019, comparing metabolic risk factors. And the conclusion was among the components of metabolic syndrome, the risk of abdominal obesity and hypertension was higher in subclinical hypo than in euthyroid subjects. Another article published in Journal of Pediatrics and Child Health concluded that subclinical hypo is prevalent in obese and that the TSH levels correlate more with the lipid profile. As you see here, higher total cholesterol, LDL, triglyceride was correlated with higher TSH. And they concluded that subclinical hypo in obese children and adolescents should be closely monitored for metabolic risk factor. Not only this, subclinical hypothyroidism predisposes to non-alcoholic fatty liver disease. It increases hepatic insulin resistance by increasing leptin, fibroblastic growth factor 1, decreasing lipoprotein lipase activity, which increases the total cholesterol and triglyceride, leading to a more vicious circle. And this is an article that confirmed that subclinical hypo is a risk factor for developing non-alcoholic fatty liver disease, and it also increases the carotid intima media thickness. And their conclusion was that obese adolescents with NAFLD and subclinical hypo are at risk of cardiovascular disease, and that thyroid dysfunction may play a role in the pathogenesis of non-alcoholic fatty liver disease. Now, back to this little girl, I decided not to give thyroxine therapy, and she came to me 6 months later after putting her on a healthy lifestyle, weight loss, and her BMI STS went down. She's still obese, but better than before. She's still tall, no goiter, and the TSH went down to 4. So this is a very good result compared to before. Still antibodies negative, ultrasound normal. So yes, healthy lifestyle did the trick, and the girl became normal just on the weight loss program without starting thyroxine. So please don't give thyroxine to obese patients with exogenous obesity. And this is a 13-and-a-half-year-old girl with 45X Turner syndrome. Of course, she came with short stature and delayed puberty. T4 was normal, TSH was highish, but still not very high. And thyroid antibodies were negative. She had celiac disease by biopsy. Her bone age was low. FSH/LH were high, and this is expected hypergonadotrophic partial horseshoe kidney. She was started on growth hormone and sex steroid. Now, on the regular follow-up or checkup, thyroid functions were repeated. The TSH went up to 8.5. So she entered into subclinical hypo, and the antibodies became positive instead of being negative before, and the bone age was more delayed, 3 years delay. So here comes the question, to treat or to wait. I think in such a case, it's wise to treat, because being Turner syndrome by itself is a risk factor. It's chromosomal aberration, TSH is going up, antibodies became positive, bone age is delaying more, so it's better to treat in such a case. So these are the latest findings published 2019, mentioning that treatment of subclinical hypo is controversial in children. Again, when to treat a child with subclinical hypo, the answer is if there is high risk of progression to overt hypothyroidism. Sorry. Okay, so here you can see criteria set in this article, very clear. The low risk if it's idiopathic, and the high risk if there is a pathology in the thyroid. If the TSH is less than 10, you can wait. Above 10, you have to treat. Negative antibodies, you wait. Positive rising antibodies, more towards treating. Goiter is another risk factor. Chromosomal aberrations like Down, Turner, associated autoimmune disease like celiac, prepubertal at the diagnosis is a risk factor, and female is another risk factor. Another risk factor, which is important, is the baseline TSH. And this is the most powerful predictor for progression of subclinical hypothyroidism to overt. If the TSH is above 10, it is recommended to start thyroxine, whatever the etiology, even if it is idiopathic. And there is increased risk of cardiovascular morbidity and mortality only in patients with TSH above 10. And the treatment remains a matter of debate if the TSH lies between 5 and 10. But the clear thing is that if it's above 10, you have to treat. What about etiology? Idiopathic subclinical hypo is usually self-limiting. And if there is a thyroid pathology, worsening of thyroid status is more frequent, especially if there is associated autoimmune disease like celiac. And the treatment with T4 in children with hypothyroidism-related subclinical hypo should not be under any debate, because The role of elevated TSH and coexisting cancer pathogenesis is possible. So again and again, TSH above 10, we have to treat. It's not only cardiovascular disease, but there is risk of cancer as well. And these are the guidelines proposed by ATA, recommendation for treating children and adolescents with subclinical hypo. The same question to treat or not to treat in children, the same answer, controversial in children. And the ATA recommendations put some guidelines to follow. It's better to treat if the TSH is above 10, if you have symptoms, if there is high risk of progression to overt hypothyroidism, and we mentioned the risk factor. Do not treat with a TSH of 5 to 10 with negative antibodies, idiopathic, no goiter, asymptomatic, no thyroid pathology by ultrasound, just follow up every 3 to 6 months. And the gray zone, which is even more difficult, TSH more than 2 times the upper limit or more than 8, progressive rise in TSH, positive antibodies, goiter, short stature, cardiovascular risk, thyroid pathology by ultrasound. This is the most difficult. So in such a case, you have to treat on individual basis and try to balance the benefit risk. And this is quite recent article review on subclinical hypo published in 2023, when to treat children with subclinical. Again, this is very clear, TSH above 10. If the TSH is from 4.5 to 10 and goiter, symptoms of hypothyroidism, syndromic or genetic etiology or nodular. So there are some pros and cons here. Potential benefits, improving the symptoms, the lipid profile, but this applies if the TSH is above 10, preventing overt hypothyroidism. Some drawbacks, symptoms and lipids are unusual to improve if the TSH is 5 to 10. Potential of overtreatment, you have a very good percent, 40% to revert to normal thyroid function, and of course, expense. So you have to weigh the pros against the cons. And always start by a very small dose and increase gradually and reassess every 3 to 6 months. And this is the pediatric workup when facing a case of subclinical hypo, thyroid function, antibodies, ultrasound, look for symptoms, family history, new medications, obesity, thyroid dysgenesis, renal insufficiency, syndromes, and renal failure. And this is a 10-year-old girl who came to me with a midline neck swelling, noted at the age of 2, soft and cystic, not tender, moves on swallowing and protrusion of the tongue, no pain, discharge, or lymphadenopathy, and it's asymptomatic. Again, the TSH is 11.9, and the T4 is normal with negative antibodies. So this is subclinical hypothyroidism. And when we did an ultrasound, we found a multiseptated anechoic cystic lesion, but the thyroid was not seen in the thyroid fossa. And the next step, because you cannot see the thyroid, is to do a thyroid scan. And here we found ectopic thyroid tissue in the hyoid area and inside thyroglossal cyst, while the usual thyroid was not found in place. We did a CT because it's good to make sure, because there is a risk of carcinoma in only 1% of such cases. So this is ectopic thyroid inside a thyroglossal cyst with infrahyoid, a very rare association. This management is to remove the thyroglossal cyst for fear of malignancy and infection, and to leave the infrahyoid and to start thyroxine because the TSH is above 10. In infants, the situation is critical. And this is an 8-day-old neonate who was asymptomatic. By neonatal screening, TSH is 14 with a normal ultrasound. Now, to treat or to wait, here we do not treat, except if it exceeds 20. And here, this is the proposed algorithm on how to deal with such infant, proposed by European Society for Pediatric Endocrinology. TSH above 40, you have to treat and do imaging. Less than 40, take a venous blood sample. If you have a below normal T4 or TSH above 20, you have to treat and do thyroid scan if you cannot see the thyroid by ultrasound. If TSH from 6 to 20, do retesting after 2 weeks and imaging by ultrasound and or scan. Now, the baby came to me 2 weeks later. I did not start treatment. But when I found the TSH jumped to 22, I had to start treatment in such a baby. So decision is sometimes controversial when you are in the gray zone. And in infants with mild subclinical hypo from 6 to 10, a very good percent, 72% resolves spontaneously. So indications of treating infants with subclinical hypo, if TSH persists above 10 after 1 month, symptoms of hypothyroidism, or if you have dysgenesis like ectopia. And of course, we're all aware of concerns about neurodevelopment and growth. And finally, this is the latest guidelines on treating congenital hypothyroidism published by ENDO-ERN and European Society. You can see the doses and that you have to start as early as possible. And the guidelines proposed by American Academy of Pediatrics echo the latest guidelines. Above 40, you have to start. Above 20 or low T4, you have to start. And below this, you have to follow up after 2 weeks and treat accordingly. My last case is 14-year-old girl with chronic kidney disease. She's asymptomatic with grade goiter 2. TSH is highish, normal T3 and T4, negative antibodies. Ultrasound shows homogeneous enlarged thyroid gland. So this is a case of subclinical hypo associating chronic kidney disease. Again, the same question, treat or wait. I would not treat because simply subclinical hypothyroidism is controversial in chronic kidney disease. Attempts of taking unnecessary thyroid hormone treatment in asymptomatic cases can lead to excessive muscle catabolism, negative nitrogen balance. So there is actually lack of consensus whether to treat such cases or not. Again, most of references agreed that there is no need to treat if the TSH is less than 10. And if you decide to treat, you have to start with very low doses for fear of arrhythmia. And this is another article published in JCM confirming the cutoff of 10 for patients with chronic kidney disease to start treatment. Finally, this is the sick euthyroid syndrome. Again, some cases of clinical hypothyroidism fall under the category of sick euthyroid syndrome. You have to correct the condition itself. So my final conclusions are subclinical hypothyroidism is less common in children than adults. Generally speaking, most of pediatric cases resolve spontaneously. The decision of treatment of subclinical hypo in children is highly controversial. Children with TSH above 10 must be treated, whatever the cause. This gray zone of TSH 5 to 10 are treated on individual basis based on the risk factor. Children with idiopathic subclinical are self-limiting. Do not treat them if the TSH is above 10. Children with hypothyroidism-related subclinical hypo require treatment and follow-up. Obesity-related subclinical hypo do not need treatment, just weight loss and healthy lifestyle. And finally, infants with borderline TSH from 6 to 20 need dose follow-up after 2 weeks, and you decide accordingly. Thank you very much for your attention.